Hi everyone, this is Muhammad Aaqib. Sorry, I've been a bit late in completing my assignment. Um, I chose this article for eJournal Club for first module. The reason I chose this article is because I wanted to um, read about function and anatomy of the basal ganglia in the clinical context, because anatomy and physiology can be boring, and reading in clinical context can you understand a bit better, as well as you retain it a bit more as well. Secondly, the DBS has actually given us a lot of insight into the functions of the basal ganglia and its different circuitry, and because it kind of modulates those circuits, hence it was it has given me a good understanding of the basal ganglia circuits basically. The topic starts with the history of the movement disorders and treatments targeting basal ganglia, starting in 1930s with ablative procedures, in 1960s the introduction of levodopa, and in 1990s introduction of DBS. Then it talks about different circuits of the basal ganglia, which run parallel but separate, and to do different kind of movements and behaviors. And they group these circuits into motor, oculomotor, prefrontal, and limbic. However, for the purpose of this article, they just focus on the motor circuit. Then they talk about the direct, indirect, and hyperdirect pathway. As we know, the direct pathway coming from cortex to striatum to GPI to thalamus and then back to cortex. Indirect pathway does the same thing. However, from striatum to GPI goes via GPE. In the hyperdirect pathway, basically we bypass the striatum and go to from cortex direct to ST and then GPI, thalamus, and cortex. What do these pathways do? Basically, the GABAergic neurons in the GPI and substantia nigra pars reticulator, they're tonically active all the time. And what they do is, they have an inhibitory action on thalamus and the brainstem. I just mentioned a couple of things. So as we know, all the information from beta ganglia goes to the cortex via thalamus, and thalamus is put in inhibition at rest when we're not doing anything by these GPI mainly. And these basal ganglia circuits are just viewed as holding the thalamus in break and in check. And then the level of this tonic and physic inhibition is determined by the interplay between the three circuits. The hypokinetic diseases are associated with the increased basal ganglia output, resulting in decreased inhibition of the thalamus, while hyperkinetic with increased inhibition of the basal ganglia output, while hyperkinetic diseases are associated with the abnormally low basal ganglia output, with the decreased inhibition and more activity of the thalamus and more movement of the thalamus and cortex. Then it talks about the pathophysiology of the Parkinson's disease. It defines it and talks about its cardinal motor features, that is akinesia, bradykinesia, and tremor, and muscular rigidity, which happen early in the disease, and then talks later in the disease the other signs and symptoms emerge, especially gait and balance problems and cognitive issues. And then talks about the role of PPN as well. Then it talks about the indications of DBS for Parkinson's disease, and it listed in 4 main indications, that is highly disruptive dyskinesia, unpredictable off-start times, motor fluctuations, and medication refractory tremor. Then it talks about the oscillatory activity and the concept of local field potentials, and the ones which Dr. Bhatti mentioned in his lecture as well. It talks how with the help of leads of the deep brain stimulation, we can record the neuronal electrical activity, and then it talks about in what they define, and they kind of explain the term local field potentials for that activity, which records basically subthreshold and suprathreshold um, uh, electrical activity, and they've noticed that in Parkinson disease, the activity which is recorded is in a beta range. However, in the normal state, when the PD patient is treated with levodopa, this oscillatory activity is basically in the gamma range. It is thought with this theory that basically what happened in the PD is that a group of neurons, they're firing synchronously, and which causes these slowness of movement or hypokinetic features of the disease. However, when we're treated, that synchrony is lost, and the desynchrony, which is thought to be normal phenomena, normal people. And then it talks about a bit more in detail about what's the ongoing research about it has been. It talks about dystonia's definition, then it basically talks about its pathophysiology, and it talks that in dystonia there is increased activity of the striatal neurons to the direct pathway as compared to the ones in the indirect pathway. Then it comes to the DBS itself, and talks about the two main targets for DBS for PD are ST and GPI. However, for dystonia it's primarily GPI. There are other targets. For example, they talk about thalamic targets, PPN targets, and STN targets for dystonia, but they're all under research. And then it talks about STN versus GPI, and what's the main difference between them in terms of, I guess, how they work, or what are the theories. So what they describe is they give this picture where they show us that GPI basically has got is a larger inside as compared to STN. That's one thing. The second thing is STN is surrounded by a lot of other structures: the thalamus, the substantia nigra, and the internal capsule. And so they also, given its a smaller size, given its proximity to the other structures, it is thought that the side effects we experience from STN are more, or you have to be very precise about where you put the target in. But having said that, there are also theories that maybe STN maybe works better because of these reasons as well. Because apart from STN, we stimulate the surrounding areas as well. So when we insert DBS in someone, and then how quickly the patient responds. So there are different symptoms respond differently. There are some symptoms which respond rapidly, and it is thought to be modulated by ongoing neuronal activity changes. The example for this includes a tremor response in PD and ET, and also bradykinesia, etc. And then there is the delayed response, which is thought to be synaptic plasticity changes, and that's the example for that is dystonia, where it takes days to months to work. And when the DBS is stopped, the effect turns off on the same rate as it developed. Mechanism of action for DBS is unclear. There are different mechanisms which are postulated, which I've listed here. In the interest of time, I'll skip. And at the end of the topic, it summarizes what we have discussed before. It talks about it talks in detail about what we think about the role of basal ganglia in movements. Is the basal ganglia primary a movement generator, or is it just an assistant? And then it talks different theories and basically conclude that it's just an assistant of the activities for the cortex, and that is kind of proved by the fact that when we do a stereotactic surgery and we remove big chunks of the basal ganglia, then patients still can have a lot of normal movements. So this is called a paradox of stereotactic surgery, and then it again talks a bit more about the synchrony and desynchrony concept in the pathophysiology of the basal ganglia, and then also talks about the future developments in the DBS, and especially focusing on the beta oscillation theory, and as Dr. Bhatti mentioned in his lecture, that in the future thought is that if we could record these beta oscillation recordings with the DBS electrodes and stimulate at the same time, then we could use those oscillations, level of the oscillations, to kind of change the settings of the DBS. So I just mentioned a couple of things. Like this article I thought was a bit advanced for my level of knowledge, but I think I got what I wanted out of it, and I would highly recommend if you have time. It took me a lot of time to kind of read it and understand it and grab most out of it, and also in giving a peer review for this article. I don't think I have enough knowledge to comment about the article at a peer review level. However, I'll give a quick big feedback at our level, which is basically I thought the article was slightly detailed. There were some discussions which were in the research at the moment, and if they were kind of omitted, I guess it won't have changed the message of the article. And there was certain information that were repeated. The articles could have been summarized a bit better. The good thing about the article was it gave a really good details about the circuitry of the basal ganglia, and good discussion of the pathophysiology of PD and dystonia, and a very good brief introduction of DBS's indications and principles and future perspectives. We'll stop. Sorry, I spoke fast because I wanted to get to cover more about this topic. Thank you very much.